Attendant.
Attendant.
Every session kena ambil attendant.
Okay.
Siapa head? Akil
Saya.
Okay.
Kita.
So tomorrow tu join. Siapa yang jadi patient?
Hazila.
Saya Dato.
Okay. Siapa yang kelak?
Saya.
Okay, both of you are ready
Kejap.
I think we should start So both of you kena buka I want to see how you clap communicate.
Okay.
Okay, start
Hazila okay?
Okay.
Okay, so first I will introduce myself. Okay, so hi, my name is Wan Asma Huda binti Wan Yahya. You can call me Asma. I'm third year medical student from Wida University College. Are you, mana nama dia? Pavitra, anak perempuan nama sekian tu.
My name is Prabhati.
Pavatri, okay. Your age?
78 years old this year.
Okay. Can I take a history based on your disease, that how did you come to here, so I can take consent from you to ask some question.
So I was admitted here. I come here because 2 days ago I have difficulty in breathing, and I also feel chest pain. That's why I came here and admitted.
Do you know where is the pain radiates to?
It's radiating to the back.
Radiate to the back, okay. Before that, I forgot to ask about, are you comfortable with your condition now? Doktor nak tambah ke? Saya sebut ni, pasal comfortable kau nak ambil consent.
Dato' nak cakap apa?
Do I need to kita? Okay, kita continue lah Okay, so about the pain, comes suddenly or he have been regularly building?
It comes suddenly. Before this, I was happy, but suddenly 2 days ago, I feel difficulty breathing and the chest pain.
Okay. Does the pain move anywhere else other than the part that you mentioned?
No, it just to the back only.
Okay. Apa? Do you have any weight loss or do you have anything that you want to tell me?
When I feel the chest pain, I didn't.
Jangan beritahu. Ini medical student, dia nak belajar, nak tahu apa nak tanya. Jangan beritahu banyak-banyak. Biar dia tanya dulu.
Feel the pain like pricking.
Okay. Can I know when your pain come to your side of pain, is it worsening or improving if you do something or else?
I don't think so. I didn't take any medicine to relieve the pain.
Okay.
So I don't know.
Do you feel any dizziness?
No.
You have cough, right?
Yes.
Is it?
I have this since last week.
Yes. Since last week. So is it dry cough, or can you explain to me?
It's like no sputum. Just coughing, on and off intermittently.
Okay.
But it loosen when I sleep during the night.
Alright. Can I ask you this based on your experience, the severity of the cough between 1 to 10 or um, bad or good or is it just moderate? How do you feel about the pain? The cough that you have?
Like it's not painful, but I have trouble in daily life to do any chores.
Oh,
Yeah.
so what you do to what to make it better?
Usually, I will sleep on
In
the
your
pillow.
sleep?
I stack the pillow like 2 to 3 pillow. So it make me feel better, make me relieve the breathing difficulty and also the cough.
Okay. So after that you will feel relief, right?
Yes, but it's like on and off.
On and off. Okay.
Yes.
So the duration. Uh, actually acute. Okay. That's all. I think. Maybe I will ask about. Um, you don't have fever, right?
No,
Okay.
no fever.
Okay. Basically, I think that's all that I want to ask. To you. Thank you so much. I don't know how to summarize, but I will let Dr. Sapari to add on some more. Or you can betulkan apa yang saya salah. Okay, that's all. Thank you.
Itu saja.
Yeah.
Okay, anybody want to comment? Nur
Anyone else?
Matira. Can you comment about
Matira,
taking?
tanyalah question. Banyak lagi question boleh tanya.
Belum lagi. Tanya tadi your friend tadi clerking ni. Okay, comment.
Komen, silakan.
No. Whatever is already asked, you just comment on that. Bukan yang belum ask. The start from approach to patient until whatever question has been asked by your friend. Itu saja. Itu you just comment on that nanti. Yang lain belum lagi. After this, I will ask one of you to collect again. What is the method of history taking? This one is open and history taking ke atau closed and history taking. Most of the question ask what type of history taking.
Open.
Is it guided type of question or non-guided type of question?
Guided.
Example?
You have
Example
Can
apa?
you explain?
Guided. Banyak guided kan? Apa dia?
You have cough. Can you explain to
Dia
me?
tak ada batuk, dia tanya ada batuk kan?
Yes.
How you know that patient ada batuk? Okay. Lagi? Fever kan?
Yes.
Tak ada demam kan? How you know that patient tak demam? Sebab you dah tengok isteri. So it must be open. Kalau open memang tak boleh, like this state I tak bagi open sebab you know you bagi tu semua. I want non-open type. So I want to know how do you get history from patient. What information want to know. Therefore I do not allow you for open type of history taking at this level lah. Okay, bila kelak through a real patient, and then that one is okay. But during this session, I'm not allowed to do that. But I want to see how good you, how to get the information from patient, all the information about the disease. And then from that, no, I want to know, okay, how you get it? Whether by asking question or by leading guided type of question. Okay. So in this case more of a guided type of question. Ditanya, you tak ada demam kan? You ada batuk kan? Cannot. You must ask first. First, what is the main complaint?
Difficulty in breathing with chest
And
pain. Chest pain.
chest pain. So how do you approach this one? What is
Chest
the
pain,
next question?
Socrates? No?
So you must ask detail about the chest pain. You must ask detail about the difficulty in breathing. Tadi dah ada kan?
Ada. Tadi tak ada difficulty in breathing.
After that, apa tu, do you have any other problem, any symptom? Kalau patient senyap je, I prefer you senyap je dululah, okay? At your level, bila nak belajar. Let that your friend ask, okay? Okay, lepas the next question, do you have any cough or not? And then bila ada cough, you elaborate further from patient. Kalau boleh bagi tahu lagi tak apa pasal batuk ni, so you kena quiet dulu, okay? So let your friend ask apa yang nak, what information you want to get from the that symptom cough. How long is the cough? How severe is cough? And then severity of cough, there is no grade for severity of cough. Mana ada someone cough 1 to 4, mana ada? 1 to 10 ada. So 1 to 10 is only for pain. Not cough. How you want to know how you want to assess severity of cough? It just based on history, okay. Okay, how often is your cough? Is it continuous cough? Is it on and off?
Okay.
If on how is on and off, usually it lasted for how long? Okay, and then the timing of the cough. Is it throughout the day, throughout the night, or worse during the night? And then did the cough disturb you, your sleep? Did the cough disturb your daily activity? It disturb what type of disturbance? Cannot sleep, cannot eat, for example, cannot do perform your ordinary work, whatever work like that, okay? And then during the meeting, during work in the office, okay, you cannot perform that because of trouble coughing, and then you know that is severe. And then smile, okay, usually just for few minutes or few seconds, and then in the afternoon get better. For example, after took what cough mixture and then get better or become less like that, did not disturb anymore. And then you know, okay, the cough is not that severe, and then improve in medication. That's it. How do you assess the severity of cough?
Okay.
There's no grading of severity of cough. That was 1 to 10. So okay, okay, anybody want to try lagi? Natasha. Mana Natasha? Okay, you start balik. Start then how do you approach patient? Tadi dia punya approach pun tak berapa bagus . So you must good morning ke, assalamualaikum first ke, and then you introduce yourself, and then what you going to do, okay, like that.
Okay.
You start balik. So mana tadi siapa? Natasha.
Asma.
Okay, you start balik.
Tak balik.
Start balik Atal.
Same people or different people, Dato? Same people or different person? Same person or different person?
Same patient.
No.
Clerk.
Okay, nak tukar orang pula jadi patient.
Tak. Tu yang doktor. Doktor tukar nama.
Orang lain.
Doktor, siapa yang clerk tu? Nak sama ke nak orang lain?
Kelab orang lain. Tadi Natasha suruh kelab. Saya dah suruh Natasha tadi.
Tadi Asma lah doktor.
Tadi Asma, Dato.
Jadi Asma, lepas tu doktor nak Natasha pula clerk macam tu.
Tukar orang lain pula.
Okay.
Try.
Okay.
Patient nak tukar pun boleh. Tak payah tukar pun tak apa. It is good patient. Okay. Natasha mana? Ready tak? Okay.
Sekejap eh. In English or in Malay?
Tak kisahlah. Tapi your friend cannot speak Malay kan?
Yes.
How many of you yang tak boleh speak Malay?
3.
Senang aja.
3 people.
3 ha. So it's better in English.
Wait, I'm the doctor. Oh, sorry.
Yeah.
Okay, Assalamualaikum and very good morning, Miss Parvati. Madam, is it madam? Okay. So I'm a student from Midat University and my name is Natasha and I'm here to clerk you. So how do you feel about today, Madam Parvati?
Balik. Kenalkan diri dulu.
I already introduced myself.
Tak dengar lah.
Sorry.
Aku tak dengar.
I'm sorry. So I'm actually a Midat University student and I'm here to clerk you. My name is Nurul Natasha and I'm a third year student. So how are you feeling today, Madam Parvati? Did you hear me? I'm sorry.
Tak dengar ke? Saya dengar.
Hazila tak dengar ke?
Zila.
Sekejap. Bagi aku soalan lain. Sekejap. Okay. Hello?
Hello.
Okay, on it.
How are you feeling today, Mrs. Parvati?
Today I'm feeling okay, good. Quite better.
Quite better than yesterday.
Yeah.
So I saw here that you were admitted 2 days ago with complaint of difficulty in breathing, right?
Yeah.
So how today compared to the way you
Start daripada asal lah. That you don't know anything about this patient. Let's say you don't know anything about this patient. Start
so
from
this is the
beginning.
first day. So can you tell me your condition?
So I come here.
Yes.
Because difficulty in breathing and also chest pain.
So does the chest pain radiating? How do you feel that chest pain?
It's like
Radiating?
it's radiated to my back, and it feels like pricking, you know.
I see. So this pricking, how do you feel about it? Is it like really, really hard or is just a little tiny needle on your back?
Tiny needle.
So during this pricking, nature that you feel, do you feel any other things?
So when I feel the chest pain, I notice
Yes.
that I'm sweating profusely. Yeah. That's what I have.
see. So that's why you went to the emergency.
Yes. I also have difficulty in breathing. It's hard to breathe. So that's why I come.
When you have that difficulty in breathing, do you produce any sputum or just cough? Wait, do you hear me?
Yes.
So when you have that difficulty in breathing, do you also experience any cough or sputum with it?
Oh yes, I experienced cough since last week actually. This
Okay.
difficulty in breathing since 2 days ago, but without I've experienced since last week already.
Oh, do you notice any time that this cough worsen or elevate?
So it's actually I have discussed it's like intermittent, you know, sometimes in day, some day in night. But I noticed that it worsens, especially at night and during cold environment or rainy.
So there's only cough and nor fever or runny nose. You don't feel sore throat at all?
No, only cough
I see.
and no sputum.
Do you feel any loss of appetite? And you feel
No,
like you've slimmed a little bit?
no. I can
None.
I eat regularly.
So,
Pasal difficulty in breathing, no net.
difficult in breathing. Wait.
So you know,
So,
I experienced this difficulty in breathing while resting. You know, while I watching TV. Suddenly, not during exercise or what, during resting.
so if you sleep, then how do you feel about that? Do you feel
So
comfortable in sleeping?
no, I especially have difficulty in breathing during sleeping.
I see. So, regarding your past medical history, do you have anything that you want to tell us?
So I since 30 years, for 30 years, I have diabetes mellitus, hypertension, and hyperlipidemia.
Then, do you have any follow up after that?
Initially I go to klinik kesihatan, but now since 12 years ago, I follow up at MOPD.
What do I ask now? So, since you have diabetes, right? You have diabetes, right? Did you notice any differences in your urine? Is it?
Okay, so because I have diabetes, so I usually have frequent urination. Okay, so my urine also a bit frothy.
Okay. So your how about your what is it? Wait, is it is okay. How about due to this diabetes, have you ever been admitted to work before? These past 30 years?
Um, I think not only due to diabetes, also due to other condition also. So last year I was admitted 4 times. This year already admitted 2 times. This time is the third time I was admitted this year.
So the reason of most of that is because since you
That's it.
said it's not only for diabetes, right? What's the reason for your admission to work?
Tak tahu lah, tanya nak Miss Pawati.
So can you tell me a little more about your family?
My family. So I have 8 kids, okay? But 5 of them already died due to lung cancer, bladder cancer, myocardial infection, heart failure. My husband also died 12 years ago because of kidney disease.
So you don't So what about your parents?
My
What about your
mother
parents?
has diabetes and hypertension, also asthma. My siblings also have diabetes mellitus and hypertension, but I have
But you don't know.
siblings. I don't know how many of them have this disease.
So for your life, how do you especially spend your life with? Are you a smoker or?
Oh no, me and my family members, none of them are smoker. We also didn't drink any alcohol.
Oh, that's good for you. So, and do you have any history of blood transfusion?
No.
Uh, for your food intake, do you have any allergy to anything? Actually, not just food intake, but just anything.
I cannot eat seafood and prawn.
Okay. Oh, wait, I don't know. Wait, how to finish this?
Thank you for your time.
Thank you for your time, Pan. Mrs. Parvati. That was so nice of you. Thank you for answering my question.
Anybody want to comment? So siapa nak komen? Anybody dah biasa pergi mana-mana klinik ke? Tanya-tanya patient ke? Family members ke? Kelak-kelak ke? You don't have experience. So anybody want to comment? Patient is okay. The doctor you comment on the doctor
Nervous? Doctor nervous.
Yes, I'm too nervous for this.
Anybody want to comment?
No.
So I already teach you how to approach patient with chest pain So what do you think? Still think regarding the chest pain? Complete, not complete?
No.
No, not complete.
No.
You had to use that Socrates, is it?
Yes.
Among that Socrates, how many not us?
I think on set.
Lagi?
Said the severity.
The side.
Severity.
Severity.
Severity you must mention, okay.
Yes.
How bad is your chest pain? And then if patient cannot describe, okay. Let's say I give you 1 to 10. Okay, 10 is very severe, cannot sleep, disturb your activity. 1 is
The
body mass,
medication.
not medication, no massage, okay, you feel okay. That one is 1. Okay, tell me now, what stage? This is how you ask patient. Okay, to find out the severity of chest pain. So what else for the chest pain? Side, okay, mention.
Side
Relative, mention. Mention, and then the character of the pain.
Mission.
Patient mention apa tadi? Character of pain.
Prickling.
Nature.
If patient cannot describe, cannot describe, and then you can give you can guide. Okay, is it pricking? Is it pulling? Is it compressing? Is it stabbing? And then you can guide like that. Give an example. If patient cannot describe for pain, okay, the character. So up to the character, what else?
The medication just now.
Relieving aggravating factors, okay?
Aggravating.
So in this patient, in this case, chest pain like this, what type of aggravating factor you want to ask?
What?
What type of aggravating factors that is relevant to this case? If patient present with chest pain on the left side.
Intake of breath.
Okay. Breathing, okay? Because we want to know whether it's cardiac, whether it's musculoskeletal, whether it is a lung.
Yes.
If lung, one is the nature character, breathing in nature. Second, usually in respiratory, when patient take deep breath, and then the pain become worse because of pleuratic in nature. Because the pleura, when you take deep breath, there will be a separation between parietal pleura and visceral pleura. And then prior to that, there will be a rubbing, okay, between pleural and parietal pleura. This is the cause of the pain. So that when you take deep breath, there will be a rubbing there. Inflamed pleura cause pain. More rubbing, more painful. So therefore, the pain is increased when patient took deep breath or coughing. So you must ask, okay, whether this pain, whether your pain is increased when you take deep breath, or you can try now take your deep breath whether it's increased or not, or when you have a cough. If there, so that suggests pleuritic pain or pleural pain or pulmonary. And then if not, and then did the pain increase when you walk, when you climb stairs? Before that, you ask your patient, oh, you stay in which type of house? Is it a single story, double story? Is it a flat? If a flat or double story, where do you sleep at night? Is it at the ground floor or at the first floor? And its floor, can you climb up? Do you have any problem when you climb up? Did the pain increase when you climb up? That kind of history you want to know, okay? Whether the pain increase with exertion or not. Or any other activity that increase the pain, okay? Whether it's increased with activity or not, whether it's increased exertion or not. So what else about the pain? You already mentioned site, radiation, character, aggravating factor. A lot more aggravating factors. You want to differentiate lung, musculoskeletal, cardiac. Cardiac usually increase with exertion. And then musculoskeletal, persistent pain. And then when you move your body like that, okay, the pain become more. Or you press the area, you compress, and then the pain become more. This is musculoskeletal pain. So that kind of question you need to ask. Anybody with chest pain? Okay, so now it's aggravating factor. Relieving factors? Do you do apply any ointment or balm like that to relieve pain? Do you take any medication? Do you take Panadol to relieve pain? That kind of question you need to ask. Okay. So next one. Aggravating factor, relief factor. Socrates. T what? Timing.
Time.
Time, okay. Time, okay. Is it the persistent, whether it's intermittent? If intermittent, how long it lasts? How long it lasts? Okay, time. And then it is aggravating and if stand for what?
Exacerbating.
Exacerbating, okay. Exacerbating aggravating factor as side. Severity.
Severity.
So finish already. Now you go to the difficulty in breathing. Okay. So when you present patient and then you start, okay, this is lady, Parvati, 70 years old, retired woman, admitted 2 days ago with the main complaint of chest pain and difficulty in breathing. As regard to the chest pain, the chest pain is happened 2 days ago while the patient is resting. It is sudden in onset. It is intermittent in nature. However, the severity of the pain is pain score 6, and there is no so the pain is not progressive. It's always around 6, okay, pain score. So the pain is on the left side. However, it's radiated to the back. And then the character of the pain is a pricky nature and it's increased with inspiration. However, the pain does not increase with exertion and also not increase with movement of the body. And patient did not rub the chest because I want to know whether the pain is increased or not with pressing. Okay. So patient did not take any medication to relieve the pain. So ada lagi tak about the pain? Side, severity,
Associated symptom?
delivering aggravating factors. Already mentioned. Already mentioned that, okay. Since that, okay, patient was admitted 2 days ago, and then while in any, what has been done, okay, for the pain? Whether the patient was given GTN or not, put under the tongue, nitrate, sublingual nitrate, or any other medication. That one you ask later lah. You ask later about that. What's been done in the A&E, what has been done in the ward. That one you tell that one later. Okay, later after you finish all the important information in the history. So okay, that regarding the pain and regarding the difficulty breathing. Okay, so other than chest pain, the patient also complain of difficulty breathing, which is also sudden onset in nature, and it happened at the same time with the chest pain. And it occur also at rest. Kalau it's increased with exertion, also you mentioned, okay, the difficulty in breathing is become more when patient exert the self. For example, when patient climb stairs, when patient walk up to 10 feet, and when patient want to the toilet went out from the house, patient developed more difficulty in breathing. And this difficulty is on and off. It's only on exertion. And also happen only during the chest pain. Whenever a patient did not have chest pain, there's no difficulty in breathing. And then now you have to classify this difficulty in breathing and the stage. Whether you need to use MRRC or New York Association. So you suspect this might be cardiac. You just mentioned, okay, the difficulty in breathing, this patient currently is New York Association class 2. What mean class 2? Or class 3 lah, class 3. Because patient have a chest pain not only during the difficulty in breathing, okay, but also when patient walk to toilet and then experience chest pain. When patients come out from the house, also experience chest pain. However, this session is improved when patient rest. Difficulty in breathing, not chest pain. Whenever patient patient, for example, walk to toilet, climb stairs up to first floor, and the patient experience difficulty in breathing. Kalau dia ada cough at the same time, associated with cough when having difficulty breathing, you mentioned, okay. Apart from difficulty breathing, patient also have a cough whenever patient have a difficulty in breathing, and the cough is actually dry cough. So you mentioned like that, okay. Ataupun you just concentrate on difficulty in breathing first, and then what the component you want to ask ada dalam that one, okay. The severity is actually based on the history, okay. How bad is it? Whether disturb activity or not. That one cough. And then for difficulty in breathing, there is a staging for difficulty in breathing. Depend on whether it's heart or whether it's a lung. If heart, you use New York Association. Have you find out what is a New York Association class?
Yes.
After that, you read that one. And then MMRC. MMRC, you find out what MMRC. MMRC actually for the lung, respiratory, especially COPD. You need to use this staging of or severity, performance. Actually, a performance status. Performance status, heart is New York Association. Respiratory, MMRC. So if patient have difficulty in breathing, you suspect heart, use New York Association. You suspect due to respiratory, use MMRC. Okay, you go to detail. There are a few more questions. Okay, what you need to do, you go back. After this, you read. Okay, if cough, what you want to ask? If difficulty in breathing, what other question you want to ask? That one all there. Okay, if respiratory, what question you want to ask? If cardiac, what question to ask? And then you prepare like this. Okay, if you go to the ward, you must prepare this one. Okay, every time you read to memorize. What question will I should ask this patient? What is the complaint? If cough, this question must ask. You can bring that one. Okay, you can bring that as a guide. Actually, good history taking actually when there is the eye to eye contact rather than eye to your paper. Most student don't know what to ask, and then you refer to paper. Apa lagi nak tanya? And then you look at the patient. So therefore, what to do every time you at home, you memorize. Oh, if patient when complete like this, this question should ask. If like this, so next time when you go to the ward, and then when you talk to patient, there is more of eye to eye contact rather than eye to the your note punya contact. So okay, you have to memorize that. And then ada chronic problem, comorbid problem. There are few questions you need to ask. For example, common comorbid, hypertension, diabetic, high cholesterol, kidney disease. So if hypertension, what further question you want to ask? Like the patient have hypertension and diabetic. What question? You want to know when was the hypertension was diagnosed?
What kind of medication?
Is it during this admission, during clinic follow-up, or during routine check-up? How many years ago? What was the blood pressure reading at that time? What was the reading at that time? After that, follow-up under which clinic? What type of medication? Whether it's same medication, whether add-on medication, whether the change in the medication, the result of change in medication. Whether because of not control or whether because of side effect. So you must ask that problem about the hypertension. And then the subsequent monitoring of blood pressure, whether this reading is only done during the clinic follow-up or also patient have a BP monitoring at home. And then you ask what was the reading? What were the reading at home? What were the reading in the clinic during follow-up? And then from there you can guess whether the BP is achieve the target, not achieve the target. Okay, there is a target. Patient with diabetes, patient with CKD, chronic kidney disease, the target should be below than 130 over or 130 over 80. Other than this, okay, the target is 130 over 90. If they achieve this or less than this blood pressure target reading, so that means the BP is under control. So therefore, you need to ask, okay, patient, okay, what were the reading during follow-up? What were the reading at home when you monitor your blood pressure? And then from there you get control, not control. Okay, and then what has been done for the hypertension during clinic follow-up? Any urine test done or not? Urine actually you want to look for the proteinuria. Any ECG done or not? You want to see whether there is any complication following long-standing hypertension or not? Diabetic hypertrophy or coronary artery disease. Any chest X-ray done or not? Any renal function done or not? Blood test for the kidney done or not during the follow-up? So that kind of question, you can ask patient and patient quite often understand, okay, what you want. And then, okay, that one about the hypertension. And then about the diabetes. Diabetes is a lot of question you to ask, especially long-standing one. So long-standing diabetes, you need to know, one is whether diabetes is control, not control. How you want to know whether diabetes is control, not control?
Blood sugar level.
One is the symptom of hyperglycemia and symptom of hypoglycemia. So uncontrolled diabetes is not only very high sugar. If very low sugar, also frequent hypoglycemia also considered as poorly controlled. Okay, the definition of good diabetic control is when there is no hyperglycemic symptom, when there is no episode of hypoglycemia, and then patient achieve the target. What are the target of the diabetic? One is the fasting sugar less than 6. 2 hours blood sugar or random sugar less than 8. And the 3-month sugar HbA1c reading less than 6.7. But some patient, elderly patient with heart disease, HbA1c target is 7. But other than that, healthy patient, no cardiac problem, the target should be 6.5 and below than 6.5, the HbA1c. That considered as achieve the target of diabetic. And then there is no long-term diabetic complication. I want to know whether there is a long-term diabetic complication or not. Based on history itself also, it can tell you, okay, whether this patient have diabetic complication or not. The macrovascular and also the microvascular. What are the symptoms of microvascular? Eye. Any visual problem or not? Do you check your eye with any doctor or not? If yes, what the doctor told you? Any problem or not in the eye? Do you have any treatment or laser treatment like that? Okay. If there is a laser treatment to the eye, that suggests this patient already have advanced diabetic retinopathy. Patient already have retinopathy. Okay. If there is no laser treatment, only follow up every once a year or one every 6 months, that suggests there is a diabetic retinopathy but in the advanced stage because no laser treatment yet. So that one for eye. And then for the kidney, the doctor told you that your kidney is already affected. The doctor told you that there is already protein in the kidney and the urine. If that suggests patient already have proteinuria. Or did any blood test not done to check the kidney function or not? If yes, what the doctor told you? Any problem or not? Yes. Do you know what stage is it? It is stage 1, stage 2, stage 3, stage 4. Some patient didn't know. Okay, doctor told say, oh, they stage 2 already. You know, okay. CKD, diabetic nephropathy, actually there is a stages. Same like other chronic kidney disease. CKD1, CKD2, CKD3, CKD4, CKD5. I will tell you later about what do we mean by CKD1, CKD2, based on GFR, based on GFR. Okay, and then for the kidney, and then for the nerve, neuropathy, there are numbers of neuropathy. One is peripheral neuropathy, one is autonomic neuropathy. Peripheral neuropathy, what the symptom? numbness, painful, hand, foot.
Loss
Okay. So if there is a numbness of the hand, numbness of foot, how long already like that? And then if
Diabetic
present, that suggests the patient have possibility of peripheral neuropathy. So ada neuropathy apa?
diabetic foot, loss of sense of pain.
Okay, present on diabetic foot, amputation like that. And then if patient feel the both leg are cool, cannot stand with cool. That feature of what? If cool, it's raining at night, my leg very cool, I cannot stand it. What that suggests? That might be a peripheral vascular disease. What are the symptoms of peripheral vascular disease want to ask? Claudication, intermittent claudication. You ask patient, when you walk 10 meter, 50 meter like that, do you feel any pain at the calf or not?
How about
Yes, and then you ask whether that pain at the calf get better or not when you take rest. If yes, that suggests the patient has peripheral vascular disease. So that one. Other than that, what other macrovascular other than peripheral vascular peripheral vascular disease? This is not common. There are other peripheral vascular disease which is more common. What symptom you want to ask for macrovascular?
varicose vein?
Oh, any angina or not? Okay, angina, difficulty breathing, that's a heart, brain, stroke, any unilateral numbness or weakness or not, which is persistent. If persistent, that means stroke. If intermittent, mean transient ischemic attack. So you have, if patient have, and then lasted less than 24 hours, that one is the transient ischemic attack. It lasted more than 24 hours, that one is a stroke. This is the difference between stroke and transient ischemic attack. So that kind of question you need to ask. Unilateral body weakness or numbness. Sometimes you have vertigo, giddiness, that suggests of brainstem lesion, brainstem vascularization, macrovascular. So the kind of question you need to ask. Okay, that one is a macrovascular. Microvascular, eye, kidney, nerve. And then nerve, neuropathy, you have somatic nerve, peripheral neuropathy lagi. Autonomic nerve. What are the signs and symptoms of autonomic nerve? Usually autonomic quite late complication
Weakness.
of diabetic neuropathy. So example apa?
Weakness.
Weakness, no. Male patient? Important.
Erectile dysfunction.
Important for male patient. Others patient? Diabetic gastroparesis. There is no peritonitis movement of the stomach. When you take meal, after each meal, you vomit it out. Because stasis of the stomach. Because there's no peritonitis, because autonomic neuropathy. This is for, okay, you ask any vomiting or not after each meal. And then constipation, nocturnal diarrhea. So diarrhea only occur at night. So these are all pictures of autonomic neuropathy. What are the picture of autonomic neuropathy? Loss of gastric sweating. Usually if you go to the, you come out from the house, very hot, you should sweat. Or you drink hot water, or you eat hot food, and then usually you sweat. Spicy food, sweat. But in diabetic autonomic neuropathy, patient might not sweat. If patient not sweat, or sweat a little bit, not as usual before, not like before, that suggests the patient autonomic neuropathy. Okay, this is symptom of autonomic neuropathy. Okay, so what are the complications you need to ask? So diabetic, lot of questions you need to ask. So at your level, you have to go to detail for each comorbid. You have to learn how to get history. But when you work, you just focus to only the acute problem or other important problem. But as a medical student, you need to learn in detail all this. So diabetic, what else in the diabetic? Of course, the medication. Okay, type of medication. If insulin, how many type of insulin? How many time injection? If a tablet, and then how many type? If patient cannot tell you the name, just ask the color, the shape, how many times per day, and then from there you can guess. So the medication, okay. And then, okay, that one for the diabetic. So this is very common, bread and butter. So you must know. what question you should ask. Okay, if patient in the stable state, patient come for something else, but patient have this comorbid problem, what question you want to ask? This is a question you need to ask. So okay, actually in the case, in the note that one, actually what I discuss is there, is it? Kan ada kan about the diabetic kan?
Yes.
Symptom of hyper, symptom of hypo.
Yes.
What are the symptom of hyperglycemia? Lethargy, polyuria, polydipsia, okay? Feel thirsty, often thirsty, feel need to drink a lot, often need to urinate a lot because osmotic diuresis. And then you lost a lot of water, and also electrolyte, because a lot of electrolyte, patient may feel lethargic, like that. So this is symptom of hypoglycemia. Hypoglycemia symptom? What is the hypoglycemia in diabetic? The mild one, not the severe one. Severe one, patient may confuse and then coma.
Yes.
Mild,
Tremors.
increase in sympathetic activity. What are the symptom?
Tremors.
Sweating, tremors, palpitation, and then feel hungry, dizzy, going to black out. So this symptom of hypoglycemia. So okay, if you ask, do you have hypoglycemia? Most of patients, they don't know what is hypoglycemia, unless some educated one. So they know hypoglycemia. You have to ask. So therefore, you want to know whether they have hypoglycemia, you just mention. You feel any symptoms such as do you have any problem with low sugar or not? I don't know. Okay. Low sugar, when you feel hungry, at the same time you feel you're sweating a lot, and then palpitation, and then shivering, and going to giddy. Okay. Feel hungry a lot. Do you have that episode or not? If yes, how many times per month? And then what is the cause of this? What do you think? Okay, why you have this low sugar? Whether you exercise too much, whether you take less food, or whether you miss food or not, that cause. Or whether you already have kidney problem, and then your medication not changed, okay? That also can cause hypoglycemia. Okay, so all the drug excreted in the kidney. If patient already have advanced kidney problem or deteriorated renal function, so if the drug is not reduced in the dose, okay, may cause hypoglycemia. So that kind of question you need to ask, whether the patient has kidney problem or not. That can cause hypoglycemia. So that kind of complication you need to ask, any patient with chronic problem, especially these two one, bread and butter, hypertension, diabetic. So you refer back to this case, okay? I think some of that is information is still taking, okay, to find out whether the patient has macro and microvascular complication or not. Is already, I think some information already there. Okay, then more the chronic. So okay, and then lot of things to be discussed about the urine. This one, in male patient, elderly, even a lady, elderly, so it might have a bladder problem. Okay, so not necessarily all that symptom due to uncontrolled diabetic. It could be due to bladder problem in elderly, or prostate problem in men. Okay, elderly men. So problem of prostate, what happen if there is an enlarged prostate, cause narrowing or sphincter, or the urethra. So patient will have a stasis of the urine. It cause frequency, other than frequency, hesitancy. So you need to press first, you have to wait and press first, and then the urine come out. And then poor stream, okay, usually stream very fast. So this one you found you found that the stream is very slow. So these are pictures of bladder neck obstruction due to prostate enlargement. It's common in elderly. So in this patient, it's lady, okay, with symptom of frequency, nocturia, and frequency whether it's due to hyperglycemia or whether due to bladder problem in elderly lady. So I think the question asked, okay, in that note. Okay, any question?
Doctor, do we have to list the differential diagnosis?
Pardon?
Differential diagnosis.
Differential diagnosis, yes.
Do we need to list
So
from
therefore you need to ask question of the differential diagnosis. You need to exclude the differential diagnosis based on these three. Therefore yang tadi tu you tanya, okay, whether it's lung, whether it's musculoskeletal, and then you ask that kind of question. If not, maybe just few there, okay, you can put a different diagnosis reason, and then you got the information there lah. Okay, the symptoms of the respiratory or symptom of musculoskeletal, for example. There's a differential diagnosis. Sometimes quite straightforward case, sometimes maybe not so straightforward. Sometimes straightforward, but there are some other
more than one
information suggestive other disease, and then you can put that as a differential diagnosis.
I see.
Okay, any more question? Okay. If not, what to do? You can practice again. Practice away about this case with your friend. You choose just one of you. Take time. Take turn to clerk. I will give you 2 or 3 more cases for you to practice. So one of your friends become a student, the other one become a patient, and then you try to clerk. Okay, and then you practice practice the 3 cases every day, 3 cases every day. By 1 week, you will be quite smooth, okay? When you want to clerk patient. Otherwise, like this, you stuck, block. I don't know what else question want to ask. So you study first. If patient complain like this, what questions you ask? If like this, what question you ask? And then after that, I give you cases, and you practice with your friend. Take turn. Okay, boleh?
Okay, Dato.
Okay, so enough for today. For the tomorrow program, I give you the timetable tonight.
Okay, Dato. Dato, I have a question regarding our
Doktor dah left.
Allah Akbar. Baru nak tanya macam mana attendance ni. Islam dah hai. Aku
Kau check kod je.
tak apalah, aku check je lah dia. PM tepi. Okay lah. Good semua tadi. Okay, bagus.
Bye.
Okay. See you tomorrow. Assalamualaikum.
Bye.